Thank you, and good afternoon. I am going to attempt to go through my presentation swiftly because I know we're behind time. So what I will attempt to do is review, because I want to provide some context about what we're doing in San Diego. So first, review our demographics and describe our agency and the Live Well San Diego initiative that has been proposed and has the political will behind it to transform our community. And then I'll share with you several Affordable Care Act supported programs that we've been implementing over the past several years. So in terms of the diversity, who makes up our county of San Diego, we are a very rich and diverse region. We have 3.2 million individuals. We are the 5th largest U.S. County and the 2nd largest in the country, 5th largest U.S. county and the 2nd largest California county. We have 18 municipalities, 17 unincorporated areas, which the county government is responsible for. We also have about 21 hospitals in our county, and public health does not provide any primary care. We rely on provision of clinical services through a large community clinic network. Based on the 2010 census, this is the breakdown for our population. There are over 100 languages spoken in San Diego. We are a large refugee resettlement site. We are the busiest international border crossing in the world. And we have 18 Indian reservations, and we are also a large military presence. So it is a very diverse community, which means we have the richness of diverse partners from which we can draw on to help us implement Live Well San Diego. Our agency director, Nick Macchione, purports and emphasizes the agency of one. The agency was created in 1998, bringing health services, social services together to form this mega agency. While the county operates on a general management system focused on strategic planning, prioritization, monitoring, evaluation, cross-threading, and recognition, which supports operational excellence. We had not done a good job at integrating within the agency all of those various divisions and programs. So this next 10 years is our vision for integration of services, and I'll explain what we mean in a few minutes. Our county is managed by, is split up into 6 operational areas that are managed by 3 regional general managers, and the regions also are responsible for eligibility operations, healthcare policy, homelessness, our veteran affairs, and other key programs. And in addition to being one of the 5 business groups of the county, the agency is composed of 5 divisions, including behavioral health services that composes or includes adult mental health, children's mental health, and alcohol and drug services. There's also child welfare services and public health, as well as our strategic planning and operational support division. And actually, I just want to go back, the pop-up there, it's key to note that public health really has an impact on all 3.2 million individuals in the county of San Diego. The other social services focus on those individuals also that are at risk and those high-risk, high-need individuals, which equates to about a client base of about 750,000 individuals. These are the various branches and programs and units within public health services. I just want to note here that in 2009, California Children's Services was brought into public health, and we also do not have animal services and Department of Environmental Health within our division, but we work very closely with them, have memoranda of understandings with them so that it is a seamless process when they have to take care of responsibilities that really are under the authority of the health officer. Now, in terms of Live Well San Diego, the vision of Live Well San Diego is a county that is healthy, safe, and thriving, and it is composed, there are 3 tenets: building better health, living safely and thriving, hence health, safe, and thriving communities. It is a 10-year plan, but we all know that it won't stop in 10 years. So this is now not just a plan, but it is a vision. It is becoming a way of life for our operations at the county, which actually began as a project and a vision of our director and a focus for our Health and Human Services Agency. It focuses on quality, efficiency, and results, and with the goal of delivering better, more efficient services to our clients. A foundational component of two of the strategies that I'll share with you shortly is the fact that we should focus on behavior to change and make a transformational change in our communities. So these are the 4 strategies for the health component. Starting out with building a better service delivery systems. Examples there that we've implemented is changing and re-engineering our eligibility operations so that clients have a better experience when they come in for services. Our nurse-family partnership would be included there. If we go next to pursuing policy and environmental changes, we've had a lot of success in that area, making those changes at municipal areas, in our school sectors, even with businesses, so that you can make the healthy choice the easy choice. And then the third, or rather fourth component, is improving the culture from within county government. We propose that if we are telling the community to eat healthy, get physical activity, and not smoke, we also have to be role models and do the same thing, and also provide those services and support for our employees. So a employee or worksite wellness program is a very strong component of the health component of Live Well San Diego. This is what I was speaking to earlier. The foundation for the health component is 3-4-50. There are 3 behaviors that contribute to 4 chronic diseases that account for over 50% of death. And in San Diego, that number as of 2009 was 56%. So 56% of all deaths are due to these 4 chronic diseases. I'd like to note, however, that while nationally cardiovascular heart disease is the leading cause of death, in the past several years we've flipped that, and now cancer is the leading cause of death in San Diego, with cardiovascular heart disease being second. And we also have established parity with the rates for stroke. African Americans were high above all of the other racial and ethnic groups, and now there is parity there. So I view that as a significant accomplishment over the past 10 years. So in terms of our journey for obesity prevention in San Diego, actually it began in 2001, actually when Dr. Flores initiated the health, or rather READY, which stands for Reduce and Eliminate Health Disparities, and we also established a Coalition on Children and Weight in 2001. The Board of Supervisors were so taken by the obesity stats in the nation, but particularly in our county, they charged Health and Human Services Agency with the task of creating an obesity action plan where over hundreds of community partners were engaged, and this action plan was created. And then 2 years later, we formed a childhood obesity initiative, which is contracted out, and that is implemented by the Community Health Improvement Partners, or CHIP, focusing on 7 domains: government, community, media, business, schools, and preschools. Those 7 domains focus on strategies related to physical activity, nutrition, and as well creating policy systems and environmental change. Also within the agency, after attending a statewide obesity or chronic disease summit in San Diego, we established a chronic disease agenda. Many divisions, the regions, were doing many activities, but there was no coordination of effort. So we created a 2-year process. During the first year, we planned, and the second year created or identified specific projects, resulting in 19 walkability projects that were identified. That served as the fodder for the CPPW grant that we subsequently subsequently were awarded. Also, as it relates to nutrition, our Board of Supervisors approved a nutrition security plan in 2009. This is basically public health and social services working together to implement SNAP, the SNAP program. Looking at it as not only as a food stamp program, but looking at it as a nutritional assistance program. All of these activities served as the foundation for the creation of Live Well San Diego. So I wanted to share with you the components of our CPPW, or Communities Putting Prevention to Work. There are three primary components focused on healthy foods, which include farm-to-institution relationships with over 20 institutions. These are some highlights of the accomplishments. This grant is officially over as of June 18th, this month. So we are very pleased with the outcomes. In terms of, one of the outcomes here is the Fresh Fund incentives, where we provided funding to support $1 to $1, up to $20 a month for individuals that are on SNAP food stamps, or we call it CalFresh, where they can get up to $20 a month to buy fresh fruits and vegetables. We created these garden educational centers around the county, and also engaged businesses to create lactation policies. In schools, we had 8 districts that developed or enhanced wellness policies to increase physical activity. 5 districts implemented breakfast in the classroom, and we also implemented 11 mini grants that were awarded for safe routes to school planning. And then regarding healthy places, this is probably, I think, we've gotten the greatest traction here working with SANDAC, which is our metropolitan planning organization, to include healthy policy supporting active and public transportation in their general plan, or rather regional plan, as well as their transportation plan. So all of these efforts over the past 10 or more years, we feel have contributed to this study, which was conducted by UCLA Center for Health Policy Research and the California Center for Public Health Advocacy, where in Southern California, comparing the FitnessGram results from 2005 and 2010, and this is measurement of 5th, 7th, and 9th graders, their height and weight, to determine whether or not they're overweight or obese. In San Diego, we had a decrease of by 3.7% percentage decrease for all of our San Diego residents, which was the biggest decline out of all Southern California counties. Now, another component, I wanted to share with you actually what we are doing with the wellness program for our employees, the changing the culture from within. You see the goals here, but the strategies each quarter using the 3-4-50 behaviors. The first year, we are now in the second year, but there is a theme each quarter, and a county champion is selected to champion that theme. These are just some of the activities that have been implemented, and we work closely with our insurers for county employees, which currently is Anthem and Kaiser Permanente. And these are the metrics. Looking at the participation of our employees, the activities that they participate in, whether they're satisfied with these programs, and looking at biometrics. We have a mobile clinic measuring blood pressure, and also we have a Love Your Heart Day, because February 14th is the birthday of our agency director, so that date has been designated as Love Your Heart Day, where we conduct community-wide blood pressure screenings, both in the county at county facilities. This year we enlisted firefighters, so people could go to fire stations to get their blood pressure screened. So what I've talked about so far is the first component of Live Well San Diego. The second component is the safety strategy. The first component, the health component, was championed now by the Health and Human Services Agency. The safety strategy, Living Safely, is championed and led by our public safety group. And these are the 3 outcome areas. HHSA is involved with the last one primarily, which is the communities are resilient to disasters and emergencies. The third component, which is thriving, is being championed by the other two business groups, LUGE, which is Land Use and Environmental, and our Community Services Group. And this should go to the Board of Supervisors next year for approval. This slide just gives you a timeline, but the important point here, there are 2 points I want to make in this slide, aside from the approvals and the reports. We issue annual reports that we take to the board. In 2009, when we decided we were going after public health accreditation, after the health component was approved, regions immediately began to engage their community residents by creating community forums and leadership teams. Using our NPHII grants, we help all of the regions standardize this community engagement process through the implementation of MAP. And so that is serving as the focus. The community health improvement plans that will come out of this process will serve as the required document for our submitting the application to FAB for public health accreditation. In 2013, later this year, we will go to the board for approval regarding our evaluation strategy of Live Well San Diego, which has 5 focus areas, including health, education, finance, community, and social connection. Across 10, there are 10 indicators across these 5 focus areas. And these are just the leading indicators. There are numerous other indicators that lead into these top indicators. So we really want to know, if we have this initiative, how are we making a difference and what successes are we making? So the evaluation plan will come. So again, what began as a Health and Human Services focus was soon adopted and championed by the other business groups within the county. And it really took on just a life of its own, and now we have all sectors across the county. We now have a recognition program where we have Live Well Cities, we have Live Well Chamber of Commerce's, Live Well School Districts, and Live Well Businesses. So we are very excited about this particular component of the Live Well San Diego initiative. Our agency director always talks about taking the accountable care organization one step further to the accountable care community. So the agency has, with the approval by the Board of Supervisors, has embarked upon developing this knowledge improvement plan, which is basically a plan to establish electronic information exchange for our county health, social services, behavioral health, public health, and our probation's data to deliver better and improved services to the clients that we serve. So taking a person-centered approach, using a team approach to identify the needs of our clients, no matter which focus or which sector they enter, not just within county government, but also in the community. These are the 5 components of the KIP, or functional capabilities of KIP. And a staff can look up or search information if a client engages any of the over 400 departments or services in the county. They can make electronic referrals. They can also collaborate with other departments where necessary. And then also they can get notifications and alerts related to those clients that can be passed on to the client if needed. And also we have dedicated staff that will look at the data that's generated from these over 750,000 clients that engage or interface with the county, so that we can do some predictive analysis about the services that we need to provide for the future. So the future regional information sharing system that we envision is that a user can access available information about their customer via a portal that will have information in our KIP system that will connect with the Beacon system that's being developed in San Diego, and can also connect with the community information exchange that is also currently in development. And that particular exchange focuses on social services, mental health services, so that there can be an integration and information can be retrieved that can assist providing the best quality care for our clients. In the remaining time I have, I just want to briefly go over the Accountable Care Act funded programs that we have been lucky enough to receive in San Diego. We have the Home Visitation Program, the Community Transformation Grant, our Community-Based Transition Program, and the NPHII grant. This slide just gives you an overview of the California Home Visitation Program. This funding is Affordable Care Act funding from Prevention and Public Health Fund that is funneled through the state, California Department of Public Health. Our goals you see there, but our primary focus is to case manage 100 first-time moms and their children up to age 2. This is building on the Nurse Family Partnership Program, which already has been in effect over the past 10 years in East and South regions. We expanded it to North, Central, and Central region, and this funding allowed us to expand these services to our additional 2 North regions. You all know about the Community Transformation Grant. Essentially, from CPPW, we continued 11 of the 14 CPPW interventions, and now we have 22 interventions for CTG. You'll see here the strategic directions, so I don't have to go through those, but we really feel that this is making a difference in making policy systems and environmental changes for chronic disease, not just obesity prevention, but for chronic disease. And the clinical preventive services we are very excited about, because we are working with the Right Care Initiative. We'll be working with them to make that intersection between community and clinical preventive services. So again, we are very excited about that activity. This, I have about 3 more slides. This is the Community-Based Care Transition Program, which is coordinated by our Aging and Independent Services Division. They are building upon a project that they got funding from through Beacon, also to manage patients that are discharged from the hospital and that might frequently be readmitted. And they saw significant success with a pilot working with Sharp Hospital, and now all 13 hospitals are on board. So they use the momentum that was achieved through that grant, the momentum that was achieved through that pilot project to apply for this funding, and was awarded this grant last year. So hospitals in high readmission rates who partner with an eligible community-based organization, these are the individuals that would apply to be involved with this program. The AIS is partnering with multiple hospitals, as I stated, 13. Participants are awarded 2-year agreements that may be extended annually through the duration of the program based on performance, and the CBO is paid an all-inclusive rate per eligible discharge based on the cost of the care transition service provided at the patient level and system changes at the hospital level. And the CBO is also paid only once per eligible patient in a 180-day period of time. So these are the hospitals that are partnering with our Aging and Independent Services. There's a total of 11 hospitals with 13 campuses, and the target is over 21,000 high-risk Medicare patients, and this is every year, beginning in January. It began this past January. So the last slide is related to our NPHII grant. This is the National Public Health Improvement Initiative, and it supports the voluntary public health accreditation process. It's a 5-year grant, and as I stated earlier, we've used the funding to support community engagement for our regions, and we really just feel that this is going to further support the transformation and the implementation of population, or the improvement of population health. The accreditation process is about continuous quality improvement and performance management. It is highly aligned with our general management system for the county, and it supports the triple aim by addressing those 3 core values that you all now know so well. But it helps to improve population health, but in the process, it helps to improve the experience of the individual as they are looking to receive quality care. And by decreasing costs, the continuous quality improvement process helps us to decrease costs, and this, for many jurisdictions, is very important now as we are faced with budgetary cuts. So with that, I thank you for your attention, and these are just contact information, should you need to contact me.
Thanks, Wilma, for another fantastic presentation. Our next speaker is John Auerbach. John is the former Commissioner of Public Health in Massachusetts and currently serves as Distinguished Professor of Practice and Director of the Institute on Urban Health Research at Northeastern University.